Chapter 13, Intravenous Therapy. IV therapy is parenteral. Types of solutions. Two types of IV solutions are crystalloid and colloid. Crystalloid solutions consist of water and uniformly dissolved crystals such as salt, sodium chloride, or sugar in the form of glucose or dextrose. Colloid solutions consist of water and molecules of suspended or undissolved substances such as blood cells and blood products. Crystalloid solutions are divided into isotonic, hypotonic, and hypertonic solutions. These terms refer to the concentration of dissolved substances in relation to the plasma into which they are instilled. When crystalloid solutions are administered to clients, the concentration influences the osmotic distribution of body fluid. An isotonic solution contains the same concentration of dissolved substances as is normally found in plasma. Isotonic solutions are administered to maintain fluid balance when clients temporarily cannot eat or drink. Because isotonic solutions have the same concentration as plasma, an isotonic solution causes no redistribution of body fluid on administration. In other words, it's not going to be swelling the cells or shrinking cells. A hypotonic solution contains fewer dissolved substances compared with plasma. Hypotonic solutions effectively rehydrate clients experiencing fluid deficits. So they are administered to clients experiencing fluid losses in excess of fluid intake, such as those who have diarrhea or are vomiting. Because a hypotonic solution is dilute, the water in the solution passes through the semi-permeable membrane of blood cells, causing them to swell. This swelling can temporarily increase blood pressure because it expands the circulating volume. The water also may pass through capillary walls and become distributed in other body cells and interstitial spaces. A hypertonic solution is more concentrated, contains more dissolved substances than body fluid. Consequently, it draws fluid into the intravascular compartment from the more dilute areas in the cells and interstitial spaces. Hypertonic solutions are used infrequently, except when it is necessary to reduce cerebral or brain edema, expand circulatory volume rapidly, administer nutrition parenterally, or treat severe hyponatremia, which is low serum sodium. Colloid or colloid solutions are used to replace circulating blood volume because the suspended molecules in the solutions pull fluid from other fluid compartments in the body. Examples include blood, whole blood, and packed cells, blood products such as albumin, and solutions known as plasma expanders. Blood, whole blood, and packed cells probably are the most commonly administered colloid solutions. 1 unit of whole blood contains approximately 475 milliliters of blood cells and plasma with 60 to 70 milliliters of preservative and anticoagulant added. Whole blood is administered when clients need fluid restoration as well as blood cells. Packed cells have most of the plasma or fluid removed, resulting in an average volume of 285 to 300 mils. Packed cells are preferred for clients who need cellular replacement but do not need and may be harmed by the administration of additional fluid. Such clients include those who have an adequate oral intake of fluid and clients who are at risk for heart failure. Blood transfusion equipment, blood compatibility, and complications also will be discussed here. There are several types of solutions containing blood products and components extracted from blood, such as fresh frozen plasma, albumin, platelets, granulocytes, and colloids are water and undissolved substances. Whole blood and packed cells probably are the most commonly administered colloid solutions. 1 unit of whole blood is approximately 475 milliliters of blood cells and plasma, with 60 to 70 milliliters of preservative and anticoagulant added. Whole blood is given when clients need fluid restoration as well as blood cells. Packed cells have most of the plasma or fluid removed, resulting in an average volume of 285 to 300 milliliters. Packed cells are preferred for clients who need cellular replacements but do not need the extra fluid, who may be harmed by it, such as a person with congestive heart failure or a person that already has adequate oral intake. Blood transfusion equipment and blood compatibility will be discussed. Blood products. There's several types of solution containing blood products, components extracted from blood, such as fresh frozen plasma, albumin, platelets, granulocytes, and sideroprecipitate. Blood products are administered to clients who need specific blood substances, but not all of the fluid and cellular components in the whole blood. Fresh frozen plasma is the liquid, non-cellular component of blood. This contains nutrients, hormones, enzymes, and plasma proteins, such as albumin, globulin, and fibrinogen, and especially all the coagulation factors. Plasma is separated from blood cells within 8 hours after collection and subsequently frozen. Frozen plasma is used primarily to manage coagulopathies, which is clotting disorders, and to control or eliminate hemorrhage caused by an overdose of anticoagulants. However, when the specific clotting factor is known or an antidote for the anticoagulant is available and the client is not in immediate danger, it is more efficient to administer more definitive treatment rather than use a generalized approach. Although reactions are rare, fresh frozen plasma should be typed and cross-matched for compatibility, just like blood. Albumin is a large plasma protein that does not normally move across the semipermeable membrane like those in capillaries. Therefore, it plays a major role in maintaining blood volume. Its presence attracts fluid to the intravascular space, a function described as providing colloidal osmotic pressure. When a person experiences hypoalbuminemia, colloidal osmotic pressure decreases, which results in movement of intravascular fluid into extravascular areas, and seen by peripheral edema in the limbs, organ edema, and cavity effusion, such as ascites. Human albumin is isolated from pooled human plasma and given to restore fluid balance in intracellular and extracellular compartments. It is supplied in strengths of 5 or 25% in 50 or 100 milliliter glass containers with special tubing for administration. Because albumin needs to run into the vein quickly, a large lumen needle or catheter is used to achieve an infusion with a fast rate, and the container of albumin must be hung at least 3 feet higher than the client's heart and infused through, again, the large lumen needle. The client must be monitored during and after the infusion to detect hypervolemia, as extravascular fluid is pulled into the intervascular space. Sometimes the doctor may order a diuretic by the IV route to avoid fluid volume overload. Platelets, also known as thrombocytes, are cell-like structures within blood that aggregate or clump together and release chemicals that produce fibrin at the site of an injury. Together with clotting factors, platelets play a role in hemostasis, which is called clotting. Platelets intended for transfusion are derived from the whole blood of pooled or single donors from which platelets have been isolated. Collected platelets are stored at room temp for no more than 5 days. Candidates for platelet transfusion are those whose platelet count, which normally is 150,000 to 450,000, falls below 10,000 to 20,000. So cases of anemia. 1 unit of 100 milliliter blood is infused, or platelets is infused intravenously over 15 to 30 minutes through a Y-set connecting a filter that is primed with normal saline. As many as 6 units may be combined in one container. Each unit is expected to raise the platelet count by 10,000 within an hour after administration. Preferably, platelet donors and recipients should be of compatible blood cell and RH types to avoid potential reactions and a less than effective response. Clients are monitored for minor fevers or possible severe allergic reactions that may occur during or up to an hour after the infusion. Granulocytes are white blood cells, also known as polymorphonuclear leukocytes, specifically neutrophils, eosinophils, and basophils. Neutrophils are the major type of blood cell that defend against infection. So a person with a low granulocyte or neutrophil count is highly susceptible to succumbing to a life-threatening infection. Granulocytes are separated from whole blood and must be transfused within 48 hours. Clients such as those who are undergoing stem cell transplantation or those for whom aggressive drug therapy to treat infection and neutropenia, which is a low neutrophil count, are unsuccessful, may be given 1 400 ml unit of granulocytes per day through standard Y-set tubing with normal saline until an acceptable granulocyte count is achieved. Vital signs are assessed every 15 minutes during this infusion. In situations when neutropenia is a predictable outcome of treatment, a granulocyte colony stimulating factor called GCSF, such as figrastim or pegfilograstim, may be prescribed to stimulate bone marrow production of neutrophils. These drugs are used to support recovery from neutropenia, not to prevent it. Cyroprecipitate, also known as cyroprecipitated antihemophilic factor, is an acellular blood component that contains fibrinogen and multiple clotting factors. Its name is derived from the fact that it is prepared by thawing fresh frozen plasma and recovering the cold, insoluble precipitate. The precipitate is then refrozen within 1 hour. Cyroprecipitate is given for actual or potential bleeding disorders when the specific clotting factor, for example, factor VIII, is unavailable, or following cardiac surgery to clients experiencing hemodilution, hypothermia, or acidosis, or to clients who require massive blood transfusions. After thawing, the cyroprecipitate is diluted with normal saline and transfused as soon as possible, or at least within 4 to 6 hours. Preferably, the donor and recipient should have compatible blood types. Each unit of cyroprecipitate contains 15 milliliters. The usual dose is 1 unit per 7 to 10 kilograms of body weight. Up to 10 units may be required and administered at a rate of 10 milliliters per minute. Platelets are the same thing as thrombocytes. A blood substitute is an experimental fluid emulsion, a mixture of 2 liquids, one of which is insoluble but remains dispersed in the other. When transfused, a blood substitute carries and distributes oxygen to cells, tissues, and organs. Many practitioners feel that blood substitutes should be more accurately called oxygen therapeutics because they do not replace all the functions of human blood. Currently, oxygen therapeutics fall into 2 categories: PFCs, perfluorocarbons, and hemoglobin-based oxygen carriers called HbOCs. PFCs, the perfluorocarbons, are solutions containing fluoride and carbon that have the potential to carry 50 times more oxygen than plasma. HbOCs are derived from 3 sources: hemoglobin harvested from outdated human blood, hemoglobin from cattle blood, and cultured bacteria in which the gene for human hemoglobin is inserted through recombinant technology, much like the production of human insulin. Plasma expanders are non-blood polysaccharide colloid solutions derived from beet sugar or cornstarch. Examples include dextran 70, 6%, called macrodex, dextran 40, 10%, called Rio macrodex, and hetastarch 6%, called hespan. Plasma expanders pull fluid into the vascular space twice as effectively as hypertonic crystalloid solutions. They are used as economical and virus-free substitutes for blood and blood products when treating clients with hypovolemic shock. However, they can affect coagulation and cause renal toxicity, intravascular fluid overload, and allergic reactions. Administering IV therapy. Selecting and preparing equipment. Equipment commonly used when giving IV therapy includes the solution, the IV tubing, and an IV pole or infusion device. A fluid warmer may be used to raise the temperature of parenteral solutions when it is beneficial to ensure stable body temperature. The nurse selects and prepares the fluid that will be administered, chooses appropriate tubing, and decides on an infusion technique. Crystalloid solutions are stored in plastic bags containing volumes of 1,000 cc's, 500 cc's or milliliters, 250 milliliters, 100, and 50 milliliters. Only a few solutions are in glass containers. The provider specifies the type of solution, additional additives, and the volume to infuse over a specific period. To reduce the potential for infection, standard practice is to replace IV solution every 24 hours, even if the total volume in a container has not been infused. Before preparing the solution, the nurse inspects the container and determines that the type of solution is the one prescribed, the solution is clear and transparent, and the expiration date has not elapsed, and there are no leaks, and a separate label is attached identifying the type and amount of drugs added to the original solution. Selecting intravenous tubing. IV tubing consists of a spike for piercing the container of a solution, a drip chamber for holding a small amount of fluid, a length of plastic tubing with one or more ports for installing IV medications or additional solutions, and a roller or slide clamp for regulating the rate of the infusion. Despite the common components, the nurse selects from various options in tubing design: primary, secondary, or wide administration tubing, vented or unvented tubing, drop size options, macro drip or micro drip tubing, and filtered or unfiltered tubing. Primary, secondary, or wide administration tubing. Primary tubing is used to administer a large volume of IV solution over a long period or a small volume through a medication lock. Primary tubing usually is quite long to span the distance from the solution, which hangs several feet above the infusion site, to the site itself. Secondary tubing, which is shorter, is used to administer smaller volumes of solution through a port in the primary tubing in a relatively short time. Y administration tubing, used to administer whole blood, packed cells, and various blood products, is also discussed. Vented versus unvented tubing. IV tubing may be vented or unvented. Vented tubing draws air into the container of solution and is used for administering solutions packaged in glass containers to facilitate their flow. Unvented tubing does not draw air into the container of solution and is used for solutions in plastic bags. So remember, vented is with the glass, unvented is with the plastic IV bags. Drop size. The opening through which fluid passes from the solution container into the drip chamber determines the drop size. The manufacturers design the drop size to deliver large size drops, which is called macro drip tubing, or small size drops called micro drip tubing. The nurse determines the one to be used. When a solution infuses by gravity at a fast rate, such as over 100 milliliters per hour, it is usually easier to count fewer larger drops than to count many smaller ones. When the rate must be infused very precisely or at a slow rate, smaller drops are preferred. Microdrip tubing, regardless of the manufacturer, delivers a standard volume of 60 drops per milliliter. Macrodrip tubing, however, varies in the drop size among manufacturers. Common macrodrip drop factors, the ratio of drops per milliliter, are 10, 15, and 20 drops per milliliter. The nurse determines the drop factor, which is important in calculating the gravity infusion rate by reading the package label on the tubing. Most IV solutions are infused using an electronic infusion device. The drop size is of no consequence with infusion devices because the rates are programmed electronically in milliliters per hour. Filters. The inline filters are a device that removes air bubbles as well as undissolved drops, bacteria, and large molecules from the infusing solution. Filtered tubing is used when administering TPN, blood and packed cells, and solutions to immunosuppressed or pediatric clients. Another factor that may affect the type of tubing selected is the technique that will be used to administer the IV solution. Selecting an infusion technique. IV solutions are instilled by gravity or with an electronic infusion device, a machine that regulates and monitors the administration of IV solutions. In some cases, the use of an electronic infusion device affects the type of tubing used. The method for calculating the rate of infusion varies depending on the infusion technique. If the solution is infused by gravity, the rate is calculated in drops per minute. When an electronic infusion device is used, the rate is calculated in milliliters per hour. There are two types of infusion devices, gravity and electronic. Gravity infusion. When IV solutions are infused by gravity, the height of the IV solution in relation to the infusion site influences the rate of flow. To overcome the pressure of the client's veins, which is higher than atmospheric pressure, the nurse must elevate the solution at least 18 to 24 inches above the infusion site. The higher the solution, the faster it infuses, and vice versa. The nurse uses the roller clamp to adjust the rate of flow. In some cases, he or she may apply a pressure infusion sleeve around the bag of solution. The sleeve exerts a squeezing action around the solution bag to make the infusion go faster. Electronic infusion devices, such as infusion pumps and volumetric controllers, are machines programmed to deliver a preset volume per hour and sound audible and visual alarms if the infusion is not progressing at the pre-programmed rate. They also produce an audible sound when the infusion container is nearly empty, if air is inside the tubing, or an obstruction or resistance to delivering the fluid occurs. Infusion pumps. An infusion pump is a device that exerts positive pressure to infuse solutions. Infusion pumps usually require special tubing that contains a cassette for creating sufficient pressure to push fluid into the vein. The machine adjusts the pressure according to the resistance it meets. This feature accounts for one of its major disadvantages. If the catheter or needle within the vein becomes displaced, the pump may continue to infuse fluid into the tissue until a default pressure is reached. Volumetric controllers. A volumetric controller is a device that infuses IV solutions by gravity by compressing the tubing at a certain frequency to infuse the solution at a precise preset rate. Volumetric controllers may or may not require special tubing. Some models allow the nurse to program the infusion of more than one solution. In some cases, when one container of fluid finishes infusing, the controller automatically shifts to infuse another. An IV infusion is ordered at 60 mils per hour with a drop factor of 60. How many drops per minute should be infusing? If you look at the example below, when using an electronic infusion device, you take total volume in milliliters over total hours you want it to run equals how many mils per hour it runs. An example, if you have a 1,000 milliliter IV bag and the doctor orders it to be run over 8 hours, then you divide 8 into 1,000 and you get 125 mils per hour. If you're infusing by gravity, you take the total volume in milliliters over the total time in minutes times the drop factor will give you the drops per minute. So for instance, if you have a 1,000 milliliter bag and you want it to run over 480 minutes, and you multiply by the drop factor on the side of the box of the tubing, in this case it's 20, and if you divide 480 into 1,000 and multiply it by 20, you get 42 drops per minute. This is how you do these problems. So your answer should have been 60 drops per minute. If you have a drop factor of 60 mils per hour, that's going to equal 60 drops per minute. In addition, monitor responses to IV infusions closely, since the older adult may be unable to tolerate the same volumes or rates of infusion as younger adults, especially if they have respiratory, cardiac, or renal disorders present. Preparing the client. You check the identity, the wristband, the client's name, and birthday. The nurse explains the purpose of the IV therapy to clients at their level of understanding. It is best to do so before bringing the equipment to the client's room. The nurse tries to make the explanation as clear, concise, and informative as possible without causing the client undue anxiety. He or she may also allow time to answer the client's questions. The nurse may address the following points: the reason that the client needs the IV therapy, approximately how long the procedure will take, what site will be used for the infusion, the amount of discomfort that normally accompanies insertion of the needle or catheter, and any instructions regarding limitations of activities. Venipuncture. This is a method of gaining access to the venous system by piercing a vein. The nurse assesses the client to detect alterations in fluid volume and implements the doctor's orders for IV fluid therapy. While the client undergoes fluid therapy, the nurse monitors to detect an increase, a decrease, or a rapid shift from one fluid compartment to another. The nurse follows the agency's infection control policies as they relate to IV fluid therapy, use aseptic techniques when caring for the venipuncture site or changing equipment, and gathers data as they relate to the presence of an infection. For all venipunctures, the following items are necessary: a venipuncture device, gloves, tourniquet, antiseptic swabs to clean the skin, a transparent dressing, tape for securing the catheter or needle and tubing, and solution. An arm board or splint may be needed to prevent dislodging of the venipuncture device. Venipuncture sites. Rigidity of veins and poor skin turgor may make a venipuncture in the older client more difficult. To avoid skin trauma, place a soft cloth or material between the skin and the tourniquet. Use of a tourniquet may not be necessary prior to venipuncture because the veins may already be sufficiently distended and easily visualized. Use of a tourniquet may further increase venous distension and venous pressure to a point that the vein ruptures when pierced, causing a hematoma, blood within the skin, or gross bleeding from the puncture site. IV therapy is administered through peripheral venous sites or central veins. Short-term peripheral venous sites are superficial veins of the arm and hand, the antecubital fossa or inner elbow, dorsum or back of hand, and forearm veins. They are the most common sites for infusing IV fluids. Scalp veins may be used in infants. Veins in the foot are avoided because infusions in the lower extremities restrict mobility and increase the risk for forming blood clots. Central venous sites are for those that deliver solutions into a large central vein, such as the superior vena cava. Selection of a vein depends on several factors, such as the client's age, condition of the veins, duration of IV therapy, IV solution ordered, size of venipuncture device, and client cooperation. Peripheral venous access devices. Several devices are used for accessing a vein: a butterfly needle, an over-the-needle catheter, which is most commonly used, or a through-the-needle catheter. All these types of venipuncture devices come in various diameters or gauges. The larger the gauge number, the smaller the diameter. The diameter of the venipuncture device always should be smaller than the vein into which it will be inserted to reduce the potential for occluding blood flow. The 18, 20, or 22 gauge venipuncture devices are the sizes most used for adults. Registered nurses who are certified may insert tunneled venous access devices, such as a peripherally inserted central catheter or a PICC line, PICC, or a midline catheter. Depending on the manufacturer, a PICC may measure 11 to 27 inches to reach from the median basilic vein to the superior vena cava, depending on the size of the client. A midline catheter is 7 to 8 inches long, but only 3 to 6 inches of the catheter are inserted from just above or below the antecubital area until the tip rests in the upper arm, just short of the axilla. Peripherally inserted tunneled catheters are best suited for clients who have limited peripheral veins or who require several weeks of IV therapy before they need replacement. Midclavicular catheters, otherwise known as axillary and subclavian veins, are not used for cancer chemotherapy, total parenteral nutrition, or solutions with pH less than 5 or greater than 9, rapid high-volume infusions, or high-pressure bolus injections. Central venous access devices. A physician inserts a central venous catheter into the jugular or subclavian vein until the tip is located just above the heart. Central venous catheters are inserted when providing TPN, monitoring central venous pressure, or administering concentrated or irritating IV solutions, when peripheral veins have collapsed, or when long-term IV therapy or thrombophlebitis, inflammation of a vein, and infiltration have reduced the availability of peripheral veins. After insertion of the catheter, a chest X-ray is taken to confirm catheter placement and to rule out an accidental puncture of the pleural membrane of the lung, which can cause a pneumothorax. Replacing equipment is important to reduce the potential for infection. Solutions are replaced when they finish infusing or every 24 hours, whichever comes first. Most IV tubing is changed every 72 hours, but the exact parameters depend on agency policy. Some exceptions include tubing used to administer TPN and intermittent secondary infusions. Y administration tubing used to administer blood can be reused one time for a second unit that immediately follows the first. Medication locks, discussed later, can remain in place for 72 hours, and venipuncture devices are replaced every 72 to 96 hours or immediately if evidence of complications develop. Central catheters remain in the same site indefinitely. Monitoring for complications. Which of the following assessments concerning an IV infusion would be a priority to report to the charge nurse? The drops are falling too slowly, a large reddened area is near the insertion site, the infusion slows when the client bends his arm, or the piggyback infusion is complete. You should have chosen a large reddened area is near the insertion site, which may indicate infiltration or phlebitis. Regarding the elderly, especially those with chronic conditions, are at risk for fluid overload and electrolyte imbalances. Observe for signs and symptoms such as alteration in cognitive function or heart rhythm, weight gain, and shortness of breath. Observe confused or disoriented clients frequently, as excessive movement or pulling on the IV tubing may dislodge the venipuncture device. Discontinuing IV therapy. IV infusions are discontinued when the solution has infused and no more is scheduled to follow. Alternatively, the venipuncture device may be temporarily capped and kept patent with the use of a medication lock, which is a sealed chamber that allows intermittent access to a vein. The nurse inserts the lock into the venipuncture device. Flushing the lock with saline or heparinized saline keeps the vein patent or open. Medication locks are used when the client no longer needs continuous infusions, needs intermittent IV medication administration, or in case of an emergency, IV fluids or medications can be given. Be aware of the drug names and strength when preparing flush solutions. Mistakes can occur because vials of heparin come in various dosages, such as 20,000 units per milliliter, 10,000 units per milliliter, and 5,000 units per milliliter, and 1,000 units per milliliter. Carefully examine orders and vials supplied when administering the drug. The nursing process regarding IV therapy. You need a nursing assessment, complete, vital signs, body weight, specific gravity of urine, skin turgor, respiratory effort, level of consciousness, and lab tests. This will all tell you in what state the body is in as far as fluids, also nutrition. Nursing diagnoses and interventions for people receiving or needing IV therapy are risk for imbalanced fluid volume. You want to calculate the rate of fluid infusion, maintain accurate intake and output always. Anytime there's an IV, you need to do I&O. There's also a risk for infection, so use aseptic technique when changing IV sites, dressings, inserting an IV, changing tubings, and solution containers. There's also a risk for imbalanced nutrition, less than body requirements. An IV does not contain all the nutrients and calories that the body needs. Total parenteral nutrition. The provider may order total parenteral nutrition for a client who is severely malnourished or cannot consume food or liquids for a long time. TPN, as it's called, uses a solution of nutrients to meet the client's caloric and nutritional needs. The composition of a TPN solution is individualized according to the client's nutritional requirements and medical condition. Because concentration of protein, carbohydrate, and fat are standard in standard volumes, however, individualization is somewhat limited. Candidates for TPN include clients who have not eaten for 5 days and are not likely to eat during the next week, who have had a 10% or more loss of body weight, exhibiting self-imposed starvation such as anorexia nervosa, with cancer of the esophagus or stomach, with post-operative GI complications, with acute inflammatory bowel disease, with major trauma or burns, with liver and renal failure. TPN solutions, which are extremely concentrated, hypertonic, are instilled into the central venous circulation where they are diluted in a fairly large volume of blood. Because of their immediate dilution, the TPN solutions do not dehydrate cells. A lipid emulsion is sometimes administered intermittently with TPN. Lipid emulsions contain fat from soybean and safflower oils, phospholipids from egg yolks that act as emulsifying agents, and glycerol to make the solution isotonic. Lipid emulsions provide essential fatty acids and are often used to meet 20 to 30% of the client's total calorie needs. However, lipid emulsions may be contraindicated in clients with elevated triglycerides. Before TPN is initiated, the physician gains access to the central circulation using a central venous catheter. Trained nurses administer TPN using filtered tubing and an electronic infusion device. For clients receiving TPN at home or as a supplement to an inadequate oral diet, cyclical TPN is most often used. Cyclical TPN is infused in cycles over 10 to 16 hours, followed by 8 to 14 hours of rest. Cyclical TPN offers the client more mobility, especially if infused during the night, and has the advantage of allowing enzyme and hormone levels to drop to normal during the rest periods. To give the body time to adjust to the decreasing glucose load and prevent rebound hypoglycemia, the infusion should be tapered near the end of each cycle. The nurse should monitor the client's blood glucose level because the glucose levels in TPN can cause hyperglycemia. Blood transfusions. Blood that is administered usually comes from blood transfusions. Blood that is administered usually comes from donors not related to the patient, meaning that it comes from a person other than the person who will receive the blood. Blood contains cells and additives and preservatives that enable it to be stored in a refrigerated state for about 6 weeks without clotting. For these reasons, administering blood intravenously requires special considerations. Blood transfusions is common among older adults and may be anticipated in those who smoke, have low body mass index, and a history of anemia, cancer, diabetes mellitus, end-stage renal disease, or heart disease. Blood transfusion equipment. Because blood contains cells in addition to water, it is generally infused through a 16 to 20 gauge, preferably 18 gauge, catheter. Blood is administered through wide administration tubing. This tubing contains 2 branches, one for blood and one for isotonic or normal saline. The 2 branches extend above a filter that removes blood clots and cellular debris. The normal saline infuses before and after the blood infuses. A port near the distal end of the tubing provides access for infusing saline from a second source if a transfusion reaction occurs. Never add medications to an IV line used for whole blood or blood products. Interaction can result in hemolysis of the blood cells. Blood compatibility. There are several hundred differences among the proteins in the blood of a donor and recipient. These differences can cause minor or major transfusion reactions. One of the most dangerous differences involves the antigens, or proteins, on the membranes of red blood cells. Antigens determine the characteristic blood groups A, B, AB, and O, referred to as the ABO system. Before blood is given, it must be examined to make sure the donor and recipient blood types are compatible. Blood is typed according to the ABO system. Everyone has one of 4 blood types, A, B, AB, or O. Red blood cells of types A, B, and AB blood have a protein on their surface called an antigen. Type A blood has antigen A, type B has antigen B, and type AB has both antigen A and antigen B. Type O has neither A nor B antigens. The blood type is important when transfusing blood because antibodies in the blood plasma will react against transfused blood cells that have a different antigen on their surface. For example, if a person who has type A blood receives type B blood, anti-B antibodies will destroy the transfused blood cells, carrying antigen B with life-threatening consequences. Because type O blood has neither A nor B antigens on its surface, type O can be given to a person with any type of blood. For this reason, people with type O blood are referred to as universal donors. However, a person with type O blood cannot receive a type other than O because anti-A and anti-B antibodies will attack the cells in the donated blood. Persons with type AB blood can receive AB, A, B, or O blood because they do not have anti-A or anti-B antibodies. Consequently, persons with type AB are called universal recipients. Some blood cells have an additional protein surface marker known as Rh factor. It's acquired its name because the protein was first discovered in rhesus monkeys. Approximately 85% of humans have this additional protein on their blood cells, which makes them Rh positive. Those who lack the protein are Rh negative. The Rh factor acts as an antigen that will cause a fatal reaction if given to a person with Rh negative blood. On the other hand, a person with Rh positive blood will not be affected by type compatible blood that is Rh negative because it does not have the antigenic protein on the cell surface. Whole blood and packed cells are typed and cross-matched in the laboratory before administration to ensure that the donor and recipient's blood types and Rh factor are compatible. Each client who needs a blood transfusion has an additional identification bracelet that is attached when the laboratory draws a sample of blood for typing and cross-matching. Before a blood transfusion is initiated, 2 nurses must check the identifying numbers on the bracelet to confirm that they match the numbers on the unit of blood from the blood bank. Complications of blood transfusion. Clients who receive blood are at risk Blood compatibility. There are several hundred differences among the proteins in the blood of a donor and recipient. These differences can cause minor or major transfusion reactions. One of the most dangerous differences involves the antigens or proteins on the membranes of red blood cells. Antigens determine the characteristic blood groups A, B, AB, and O, referred to as the ABO system. Before blood is administered, it must be examined to make sure the donor and recipient blood types are compatible. Blood is typed according to the ABO system. Everyone has one of 4 blood types, A, B, AB, or O. Red blood cells of types A, B, and AB blood have a protein on their surface called an antigen. Type A blood has antigen A, type B has antigen B, and type AB has both antigen A and antigen B. Type O has neither A nor B antigens. The blood type is important when transfusing blood because antibodies in the blood plasma will react against transfused blood cells that have a different antigen on their surface. For example, if a person who has type A blood receives type B blood, anti-B antibodies will destroy the transfused blood cells carrying antigen B with life-threatening consequences. Because type O blood has neither A nor B antigens on its surface, type O can be given to a person with any type of blood. For this reason, people with type O blood are referred to as universal donors. However, a person with type O blood cannot receive a type other than O because anti-A and anti-B antibodies will attack the cells in the donated blood. Persons with type AB blood can receive AB, A, B, or O blood because they do not have anti-A nor anti-B antibodies. Consequently, persons with type AB blood are called universal recipients. Some blood cells have an additional protein surface marker known as the Rh factor. It's acquired its name because the protein was first discovered in rhesus monkeys. Approximately 85% of humans have this additional protein on their blood cells, which makes them Rh positive. Those who lack the protein are Rh negative. The Rh factor acts as an antigen that will cause a fatal reaction if given to a person with Rh negative blood. On the other hand, a person with Rh positive blood will not be affected by type compatible blood that is Rh negative because it does not have the antigenic protein on the cell's surface. Whole blood and packed cells are typed and cross-matched in the laboratory before administration to ensure that the donors and recipients' blood types and Rh factor are compatible. Each client who needs a blood transfusion has an additional identification bracelet that is attached when the laboratory draws a sample of blood for typing and cross-matching. Before a blood transfusion is initiated, 2 nurses must check the identifying numbers on the bracelet to confirm that they match the numbers on the unit of blood from the blood bank. Complications of blood transfusion. Clients who receive blood are at risk for the same complications as those receiving crystalloid fluids. They also face additional risks. However, a transfusion reaction is an untoward event at the time that the blood is being given. One of the most life-threatening transfusion reactions is an incompatibility reaction that occurs when the donor and recipient blood types are incorrectly matched. In this instance, the recipient's antibodies destroy the donor cells. Although all incompatibility reactions occur infrequently, when acute hemolytic reactions do occur, they are accompanied by a high rate of fatality. An acute hemolytic reaction occurs within minutes of infusing the donor blood. Milder allergic reactions such as hives and itching or a febrile response may occur if the recipient is sensitive to noncellular substances in the donor blood. Delayed reactions, which are milder than incompatibility reactions, can occur weeks to months after a transfusion. Delayed reactions are more likely the result of an immune response against the antigens of the Rh component of blood cells. Because serious transfusion reactions generally occur within the first 5 to 15 minutes of the infusion, many healthcare agencies require that a nurse remain with and monitor the client during this critical time. Because the transfusion reaction can occur at any time, however, nurses monitor clients frequently throughout a transfusion for signs of a reaction or other complications associated with receiving blood. Clients are instructed to call for assistance if they feel unusual while receiving the infusion of blood. In cases of a suspected transfusion reaction, it is appropriate to stop the infusion of blood and infuse a solution of normal saline while continuing to assess the client. Non-immune complications are also possible after blood transfusion. Clients may become septic if pathogens have grown and multiplied in the stored blood or during the interim when blood is being infused. A universal standard is to keep the blood refrigerated until just before use and to infuse the blood in 4 hours or less to prevent a septic reaction from bacterial contamination. Some clients have shaking chills and a fever during a septic or febrile reaction. Monitoring the client's temperature before, during, and after a blood transfusion is necessary to determine if chilling is the result of an emerging complication or of infusing cold blood. Reduced levels of serum calcium can produce symptoms in clients who receive massive transfusions of blood over a very short time. Citrate, which is added to the donor blood to prevent clotting while in storage, binds with calcium in the recipient's blood, causing hypocalcemia. Blood-borne infections such as hepatitis A, B, and C, and HIV infection can also be transmitted through blood from infected donors. Donors are asked questions about their infection history, foreign travel, and risk behaviors when being screened before donating blood. Donated blood also is tested for hepatitis virus and HIV antibody levels. Although it is impossible to guarantee that all donated blood is free of blood-borne pathogens, the incidence of transmission is much smaller than it was at one time. To avoid the use of publicly donated blood, some surgeons administer salvaged blood. Salvaged blood is blood collected from a client during a surgical procedure and reinfused while surgery is being performed or shortly thereafter. Salvaging blood involves using a device known as a cell saver system. In this system, the blood drains from the surgical site into a collection device, a reservoir sends debris into a separate waste container, and salvaged blood is reinfused intravenously to the client. Salvaged blood is commonly reclaimed during cardiothoracic and orthopedic joint replacement surgery. Using salvaged blood eliminates the potential for transmission of blood-borne diseases, provides type-specific blood, and frees stored blood in the blood bank so that it is available to other clients who may require a blood transfusion. A physician orders 2 units of packed red blood cells, RBCs, for a client. The nurse knows that the tests the physician used to assess the need for red blood cells was it blood glucose levels, electrolyte levels, hemoglobin and hematocrit levels, or specific gravity? You should answer hemoglobin and hematocrit. These tests measure the levels of hemoglobin, the oxygen-carrying component of the red blood cell, and hematocrit, the number of packed red blood cells found in 100 milliliters of blood in the blood, and provide an index to the severity of possible anemia. This is the end of the slideshow.